Thank you very much indeed for inviting me to speak at your Irish Association of Dermatology Spring webinar. I'm Jane Setterfield and I lead the Oral Dermatology Clinic at St John's Institute of Dermatology. I've chosen this topic, managing a painful mouth, because it allowed me to select a few of the more frequent conditions that you will encounter in your practice, and hopefully my tips will be of use to your own clinical practice from here on in. I have no conflicts of interest to declare. So this is the outline of my talk. On the left, you'll see the various conditions that we're going to look at, largely forms of ulceration, including ulcerative lichen planus, cheilitis, but specifically two types, actinic cheilitis and exfoliative cheilitis, both of which can be really quite troublesome for our patients. And then finally, a slide at the end on oral dysesthesia. In terms of management, I will be showing you the diagnostic clinical clues, how to assess your patients, particularly from a clinical outcome measure perspective, and how to formulate your diagnosis where appropriate to do biopsies, and if so, how to do your biopsy. We'll look at topical and local treatments, often the same throughout these conditions, and then systemic therapies tend to be more specific to the individual conditions. And along the way, how to mitigate complications of the disease and also treatment. So the key principles of managing patients with oral problems are firstly to get yourself and the patient in a comfortable position, with the patient sitting on the edge of a couch facing you, often you and they at a similar height with a good bright light. It's important initially to establish a clear diagnosis, and that may mean investigations such as biopsies and sometimes repeated biopsies. And I will be showing you some evidence of where best to take these from. A lot of our patients with oral disease will have overlapping multi-site disease with other mucous membranes, and multidisciplinary team approach is essential. I use a lot of ENT and ophthalmic inputs, but occasionally the other teams as shown on this slide. Outcome measures are essential, and I hope I can persuade you of that as we go through the talk. Photography is helpful, although often impractical as a means of monitoring inflammatory disease, but it can be helpful for monitoring potentially malignant diseases. Oral hygiene, as you will see, is essential, and the patient needs to have a dental hygienist that they can see regularly. It's important to maximise topical treatment, and I'll reinforce this repeatedly, often the same topical treatments, and maintain those alongside appropriate systemic treatments. So the first condition that we're going to look at is recurrent abscess ulcers, of which there are three main types. And the one that you will encounter most frequently will be the patients with minor abscess ulcers, and they constitute at least 80% of the group. A small proportion will have major abscess ulcers, and in these ulcers will last much longer, perhaps 6 to 8 weeks, are often on keratinized surfaces such as the gingiva, hard palate, dorsum of tongue, but can be elsewhere as well, and may heal with scarring. They're often quite angular, as shown in this picture. And then there are the herpetiform ulcers, which are a rare subgroup, often occur later. Minor in the first decade, major second decade, and herpetiform often third decade. There are two presentations. Patients may have simple abscess ulcers, in other words, one or of those three, intermittently occurring, or they may have complex abscesses, which is when the ulcer episodes tend to merge into each other, or oral ulcers are associated with genital ulcers, but the patient does not fulfill the criteria for Behçet's syndrome. I should mention at this point I'm not going to talk about Behçet's. When patients present a little later, for example, in their 40s or 50s, think always, is there an underlying cause for their abscess type ulcers? For example, inflammatory bowel disease, HIV, vitamin deficiencies, perhaps in Afro-Caribbean patients, cyclic neutropenia, etc. In terms of investigation, well, there are not that many that I would routinely do for these patients. I would certainly check the full blood count, haematinics. If I suspect celiac disease, perhaps that they have a low folate, I would undertake appropriate blood investigations and perhaps other GI investigations as indicated. For example, if the patient has suspected inflammatory bowel disease. If I'm thinking possibly an overlap with Behçet syndrome, I'll undertake an HLA-B51, refer patients for ophthalmology screen, and possibly a rheumatology screen as well. In terms of clinical outcome measures, for abscess type ulcers, I use a very simple technique, which is shown here. It's an ulcer diary. I ask patients to print out on one sheet 12 columns for the months of the year, 31 rows, and on this sheet they will put crosses for the severity of their ulcer episode on each day that they're active. And you can see they have 1, 2, or perhaps 3 crosses depending upon their own assessment of severity. And at a glance, therefore, you can see whether or not the patient's episodes are occurring less frequently, lasting less long, and whether your treatment is therefore working. Specifically, we're interested in ulcer size, and I often draw ulcers and get patients to point with an arrow the range of ulcer size. And we've already established with our ulcer diary the frequency and ulcer-free periods. But there are more detailed ways of assessing ulcer severity, and one such method is published by Tapuni and Steve Chalicum in 2013, which uses 6 parameters of oral ulceration for their score method. How do we manage these patients? Well, antiseptics are always very helpful. Often patients will already have been using Corsidol mouthwash daily when they're having abscess type ulcers. Proxil may be helpful. Certainly barrier methods, igloo, ginger gel can be very helpful. Analgesics, Diflam as a spray or oral rinse, lidocaine gel or a lidocaine spray, which is stronger concentration, can also be very helpful. But by the time they come to your clinic, they're often in need of further treatment, and so we introduce topical corticosteroids. I use betamethasone mouthwashes. As you can see here, betazole, 0.5 milligrams dissolved in 10 mils of water as a 3-minute rinse and spit, up to 4 times a day with attacks, and twice daily between attacks to try and space them out. At the first sign of a new ulcer, in an accessible site, Dermovate ointment might be helpful, applied directly to the dried mucous membrane lasting at night. And if you wish, you can mix it with Orabase to make it more adhesive. But asthma inhalers such as Flixitide can be helpful, or Flixinase nasals dissolved in water similarly can be helpful. For herpetiform abscess ulcers, doxycycline mouthwashes, which is 1 capsule dissolved in 10 ml of water as a 2-minute rinse and spit up to 4 times a day, can be particularly helpful for those. Again, often by the time patients come to your clinic, they're in need of yet stronger treatment, and the first line agent to consider would be colchicine. This needs to be introduced slowly, 1 tablet once a day for a few days, perhaps up to a week or 2 to get the patient used to the medication, increasing then to twice a day and continued for a minimum of 8 weeks as a trial of treatment. This can be alongside betamethasone mouthwashes as well. If there's not an adequate response, you can increase to 3 times a day, and occasionally I will go to 4 times a day. But it is a toxin. It's from the crocus plant, and if you get to between 8 and 12 tablets a day, it can be highly toxic, and I think 12 is lethal. So be careful, but it's a very helpful treatment. For major abscess ulceration, prednisolone, 30 milligrams daily for a week, reducing then until the ulcer heals, can be very helpful. For patients with recurrent ulcers that aren't controlled with colchicine, I use azathioprine. And in those who are methylators and in danger of having abnormal liver function tests, this is a very handy technique, adding allopurinol and reducing the dose of azathioprine by to 25% will allow you to continue to use azathioprine quite safely. Thalidomide is a further treatment that can be used, initially 50 milligrams daily, but sometimes can be used 2 or 3 times a week at that dose with a good effect. Moving on now to erythema multiforme. This is a particularly challenging condition for patients and for us as well as dermatologists. Often patients will show you pictures looking like this: erythematous patches, often on the palate, buccal mucosa, tongue, and incipient lesions on the lip. When it starts to ulcerate, you'll see these sort of linear ulcers that merge into each other with a yellow-grey base, lots of fibrin. But notice that the sparing of the gingiva, that's a key sign that this is erythema multiforme. When more severe, these patches turn into ulcers, and you can imagine this patient's having terrible trouble being able to eat or drink, and often these patients will require admission for hydration. There's a hint here that this patient may well have had herpes simplex as a trigger, with these monomorphic vesicle type lesions on the lips. There aren't many investigations that I do for recurrent erythema multiforme. Almost all patients are likely to be triggered by an infection, and the most likely infection is herpes simplex. You won't find a swab being positive at the time of these lesions because the herpes has come and gone, and this is a hypersensitivity to having had a flare of herpes simplex. But you do need to see IgG positive serology in order to warrant intervention. Antiviral intervention. Other viruses too may be relevant, and in young people, mycoplasma may well also be relevant. But I do check for streptococci, I do an ASO titer as well. And again, you can see the ulcer diary being very effective in terms of assessing severity, frequency of attacks, and success of your treatment. Here, the patient started on azathioprine, dose has been gradually increased up to 100 here. The patient's coincidentally stopped work as well, and that combination has put this patient into almost complete remission. In terms of treatment, topical corticosteroids are always implemented with analgesics and antiseptics, but then we'll add in, if we've confirmed HSV positive serology, and the patient's having recurrent herpetic episodes, I will introduce acyclovir, 400 milligrams 2 or 3 times a day. This study here showed that in patients pardon me, with recurrent EM, 70% of them had gene products in this study present in their ulceration. If acyclovir isn't adequate after 6 months, you can change to valacyclovir, which is better absorbed. Alongside this measure, when the patients do have breakthrough episodes, I will give them prednisolone. If you catch it on the first day, 25 milligrams will suffice. But if the patient's had it for a few days, you may need to go in with 30 or 40 milligrams, reducing over 10 to 14 days. Again, if this method is not adequate and patients are still having frequent episodes, azathioprine will be your next form of treatment, and this will often reduce the frequency of attacks, or thalidomide. This was an interesting study by Sanchez-Pagan et al. In 2010. They looked at 22 patients with a range of severe ulceration, EM minor, EM major, and then they've got 3 with a separate condition, Stevens-Johnson, which is drug-induced, as you know. And here you can see the sort of treatments that they implemented, leading to complete remission in all patients in 7 to 10 days. So topical for the minor, oral prednisolone at high dose for the major, and methylprednisolone for the more severe major and Stevens-Johnson patients. So do not worry about introducing these treatments, they're essential. Here is SJSTEN, and the reason I'm showing you this is occasionally you will be called to ITU to advise on oral management of these patients. I have put this in the guidelines, actually, the SJSTN BAD guidelines. But here's just a summary of what I say. So the main complications that these patients will have if you're not careful are these fibrous bands occurring. And this can be completely prevented with the method I'm going to show you in a moment. As you can imagine, this will stop the toothbrush getting in and cleaning these teeth, and these patients will develop periodontal disease, or they will need surgery to remove these fibrous adhesions. There may be salivary gland damage resulting in a dry mouth, or even macroglossia as a long-term complication. We use swab on a stick and something greasy such as Vaseline here, 50-50, to sweep the sulci on a regular basis every few hours whilst the patient's unconscious in ITU. I do advocate a daily MCNS as treating intercurrent infection is appropriate as well. Analgesics, Stiflam, lidocaine, a nice gel clear, which is a barrier, can be helpful. And when the patient's conscious, cocaine mouthwashes may be very helpful for this severity of ulceration. And then finally, this triple mouthwash, betamethasone, nystatin, and doxycycline, can be very helpful for these very sloughy, ulcerated mouths that do get secondary infection with Staphylococcus and often Candida. And this triple mouthwash just keeps the mouth much, much more clean and therefore less painful. Moving on now to pemphigus. This is a condition that you'll all be familiar with. And characteristically, the clinical clue is these red eroded lesions. It's not typically white or yellow ulcerations unless the lesion's very chronic, perhaps on the dorsum of the tongue. It tends to be more red, and that tells you it's not a full thickness breach of the basement membrane. Multi-sites are infected, the buccal mucosa, the tongue, the lip very frequently, which you'll see is unusual in MMP, so that's one way to distinguish the two. The palates are affected, classically here at the junction of hard and soft palate, and the gingivae, when they are affected, a gingival tip involvement. And you can see terrible buildup of plaque because it's so painful. This patient's very reluctant to brush their teeth adequately, and that plaque will be stoking the flames. If you start to see this hyperplastic look in the mouth in a patient who is known to have pemphigus, do consider paraneoplastic pemphigus as well. This would be atypical for ordinary pemphigus vulgaris. So just a hint here that there's something else going on and further investigations are warranted. Moving on to mucous membrane pemphigoid, you can see now a different look. There are areas of erythema for sure, but it's a full thickness gingival involvement, commonly the most common site in mucous membrane pemphigoid. And where blisters have popped, you can see the odd blister here and there. There's a blister there, blisters on the palate. Where they pop, you do have a white, yellow, sloughy base, telling you it's a full thickness ulcer. Again, build-up of plaque, it's uncomfortable. Patients don't want to brush around these areas of inflammation because it's painful and they'll bleed. Where the teeth have been lost, interestingly, the condition improves, and that tells you something about the interplay between the oral microbiome in plaque and the disease activity. So where to biopsy to guarantee that in one hit you get the diagnosis? Well, in this paper that we published last year, we tell you exactly where to biopsy. We looked at 250 MMP and 77 PV patients retrospectively, and we found that when the biopsy was taken from normal, the most normal part of the mouth and easiest to access, anterior buccal mucosa, you have 100% positivity for pemphigus. For MMP, often the gingivae are the only site involved, and therefore you want to take a biopsy near to where the action is occurring. So you take it from the reflected alveolar mucosa anteriorly so you can access it very easily, and this will be a stable piece of tissue that won't separate, and you will get 100% positivity if you take your biopsy from here. If the ulcerations on the buccal mucosa, adjacent to the buccal mucosa would be adequate as well. How to score these patients. So this is the oral disease severity score, which has been validated for pemphigus, pemphigoid, and lichen planus. So it's hugely helpful, and only one method needs to be learnt for these three main diseases for you. Here it's shown for MMP, and there's a site score, 17 sites, an activity score for each of those 17 sites, and a pain score that the patient gives you out of 10. And you add those three scores together to give you a total score. It takes 2 minutes to do this, and by so doing, you are able to assess patients' improvement over time. This is some data for dapsone, and you can see it takes a long time for drugs to work in the mouth. This is 18 months before we have the maximal effect for dapsone in MMP. In terms of pemphigus, again, taking the score at each visit will enable you to reduce treatment. And the message with pemphigus is to allow the score to tell you when you can reduce the treatment. So don't reduce the treatment and then measure the score, because you'll find that you'll be swinging up and down in a yo-yo, because you'll be chasing the disease and not allowing your treatment to be driving the disease response. So allow your score to improve before you then reduce the dose of prednisolone, and gradually over time, 18 months, if you do this correctly, the patient will go into a clinical remission in many cases, maybe not all. In terms of topical treatment, again, it's the same treatment, topical Dermavate. You may want to use a special tray which the dentist can devise for the patient, going right up to the sulcus, and putting, for example, Dermavate in there for 15 minutes each day will certainly help. Again, betamethasone mouthwashes, Corsadil and Peroxyl, each one of these per day, and nystatin as needed, because patients will be to Candida. We know from Pascal Joly's work that rituximab is where we want to go with pemphigus, and ideally we would be using this as a first-line agent, and therefore Karen Harmon and the group of us put this in as our first-line recommendation in the hope that we might be able to influence nice decisions in the future. Pascal Joly has shown using rituximab versus prednisolone that 89% of patients with rituximab went into complete remission off treatment at 2 years when he used this in new patients. Now, for our patients, they've often been on prednisolone, azathioprine and mycophenolate for some time before we introduce rituximab. So this is a more resistant group. This is 12 patients of mine, and you can see each colour line is a different patient, but over time, post-rituximab, gradually oral scores have improved, the desmoglein titers have improved, and here summarised, meaning that data, you can see baseline 3 months, 8 months for scores after the first course, and for some needing a second course, and the same for the titers, that there's a progressive improvement. So the message is jump in there with rituximab as soon as you can and keep giving it. I'm not going into the details, but perhaps 6 monthly, dictated by their titers and their clinical response, B-cell response, etc. But keep giving it, and you will definitely help your patients very considerably. And the same can be said for severe MMP. These guidelines we've just written, this is the Working Task Force Working Group, European Working Group, and it's in press now in the JEADV. And this is just an algorithm that I've pulled from our paper. It follows on from the previous guidelines in 2002. So you can see for mild to moderate, topical steroids, dapsone, tetracyclines perhaps, adding then in layering treatment, adding in prednisolone and then a second line agent, MMF or azathioprine. And increasingly now I'm jumping across to rituximab for those patients who aren't responding adequately. Perhaps within a year of this combination, I'll be giving these patients rituximab, and certainly those with severe eye involvement or laryngeal involvement will be going for rituximab, and I'm seeing very good results for these patients. Lichen planus has multiple presentations, but the painful mouths will be the atrophic gingivae, atrophic buccal mucosae, or ulceration as shown here. So these are the ones I'm going to focus on. And those include the VVG syndrome, which is a subtype of ulcerative lichen planus associated with prominent scarring of other sites, scalp, esophagus, etc. And you can see a range of sites with a lot of scarring in these patients. So these sorts of patients will find themselves symptomatic. They'll be moderate and severe. Topical regular steroids won't do the job. We will be adding in short courses of prednisolone, usually then hydroxychloroquine as an ongoing maintenance, and adding in after 6 months, if need be, mycophenolate mofetil, azathioprine or methotrexate to manage these complex ulcerative patients. Always bear in mind, when a patient isn't doing as you expect them to do, there might be something else underlying it, as you've seen with the paraneoplastic pemphigus patient. This was a lady who presented to me in December, and these were her original photographs that she'd sent me. You can see she's got lichen planus on her tongue, ulceration on that side of the tongue, under the tongue, and a little bit on the left. She was a lady who had a past history of 5 years previously of DCIS, breast cancer, had been on long-term tamoxifen, and just before this had been started on anastrozole. And I wonder whether that may have been the trigger, albeit not described in the literature. So we stopped the anastrozole with the permission of her oncologist and waited to see what happened. But 6 weeks later, she was getting worse, and you can see extensive ulceration now in her tongue, lip involvement, sublingual, and here on the left side of the tongue too. So I immediately suspected something else was happening. This was much too rapid progression for lichen planus in the normal way. So I arranged for her to have a PET scan. I did a direct immunofluorescence and serum and sent it for analysis. Her PET scan showed that she had a thymoma, shown here, and her indirect immunofluorescence showed positive intercellular antibodies at high titer on monkey esophagus and human skin, and on rat bladder, which is shown here, again very high titer involvement, showing desmoplakinins, but all of her other known antigens were negative. So no pemphigus antigens lighting up, no BP antibodies, no type 7 collagen antibodies, all negative, which tells you she's got a paraneoplastic response going on. She had her thymoma removed. And you can see here her ODSS score pre-removal was 35, and 1 month after her thymectomy, I saw her just last week, so much better despite a lower dose of prednisolone. We'd started her on prednisolone as soon as she became worse, and now she was down to 10 milligrams a day, and you can see her mouth is so much better having removed that tumour. So bear in mind, when things aren't exactly as you expect them to be, hunt for an underlying trigger, such as a tumour. In lichen planus, of course, you're thinking always about tumours and you're looking for anything unsuspicious or odd. This painful mouth became less painful with mycophenolate, but then it started to develop this appearance, which of course is a pre-malignant potential, this creeping keratosis, progressive verrucous leukoplakia. Another patient here developing a firm, tender nodule, and that is a squamous cell cancer. And again here, this speckled leukoplakia, and this is an oral cancer here. So you're thinking painful lesions that aren't responding to treatment. What's going on? Is there a tumour? Cheilitis. We're getting towards the end of the talk here. Many forms of cheilitis that you need to consider. Just a word on lichen planus. Protopic is very helpful. 6 weeks of protopic will generally heal lichen planus on the lip. But I'm going to talk now about exfoliative cheilitis and actinic cheilitis. All patients who come to me with cheilitis, I show them the homunculus, and it's very helpful because it makes them realise that they're not imagining the severity of their symptoms. And it's helpful for their carers or family members who come with them to see this and understand why the patient's making so much fuss about their symptoms. Exfoliative cheilitis, as you know, causes peeling, exudate, weeping, crusting, secondary infection. Patients find themselves licking their lips, which might be a primary or a secondary habit, but it needs to be broken. I was looking as I prepared this actually for the BAD last year, and I looked at the literature, and the only paper I could find with any sizable group was this paper here, with a group of 15, and I compared it to my own patients, 54 patients, and you can see that women are more affected than men. Average age varies enormously, often quite young though. Lip licking is a habit that needs to be broken. Many patients are atopic, and mental health is crucial. Mental health disorders are prominent in these patients. You can see 40% in this study and 44% in mine. Anxiety, depression, OCD, perhaps eating disorders are all common, and these need to be managed. Patients must be swabbed. Commonly, they're positive, 77%, and repeatedly swabbed. Patch testing is significant, and in those who I could find that I'd done it, 6 out of 17 were positive and 4 out of 6 were relevant. So a relatively high yield and definitely worth considering. So how to investigate? Well, definitely lip swabs, nose swabs, mouth swabs, patch testing, no biopsy. That just gives you a scarred lip and often with a dysesthesia associated with it. Treat infections, oral antiseptics, minimize lip balms because it's just a culture media, and introduce Protopic twice daily for 6 weeks, reducing if possible to twice a week, but if not, continue twice daily, and refer patients for psychological help. This is essential. Without that, patients will not improve. Actinic cheilitis is the last type of cheilitis I wish to talk about today. Patients may just present with these thin, violaceous lips that sting in the sunshine, perhaps sting when they eat certain foods. They may blister and they certainly will peel. It's pre-malignant. 95% of SCCs follow on from actinic cheilitis, and up to 30% of patients with this will then develop a SCC. So it's crucial to identify and treat. There's a fantastic review of the literature, review in the literature, should I say, last year on huge numbers of patients, primary outcome, clinical response, or histological changes as a secondary outcome. And here are the conclusions. So this is all the treatments that they looked at. And I just want to point out that, of course, surgical removal will give you a 100% positive result. Laser is a close second, but these, of course, require expertise that many of us don't have. For the rest of us, look at this. 5FU, 75% clinical response, just 12 to 21 days of treatment. Yes, there's relapse, but you can repeat the treatment. And imiquimod, similarly, 73% complete response. So this is what I use. I use 5FU on my patients. This gentleman used 2 courses, 10 days, 5 days each week, a gap over the weekend in the middle, did it 2 courses of treatment, and that was his response. This lady had terrible actinic damage all over her face, 2 courses of it, of Effudix, 3 weeks, with a gap of a couple of months, and look how good her response has been as well. So I wholeheartedly recommend 5FU for actinic cheilitis. And just finally, oral dysesthesia. If you look in the mouth and can't immediately see why the patient is complaining of discomfort, check for oral erythema migrans. It may be very subtle, just a hint, a little circular lesion dotted somewhere. And for these patients, you need to do their hematinics because optimizing these may be helpful. Difflam mouthwash. Look for candida. Is the mouth dry? If the mouth is dry, there may be salivary gland hypofunction. And again, that might need further investigation in a dry mouth clinic. Check their ANAs and ENAs. And if there is candida, obviously treat appropriately. But if it's on the background of a dry mouth, it will need ongoing maintenance treatment on a monthly basis. Check for parafunctional habits in those patients in whom you can see no other explanation. They might be rubbing their tongue against their sharp teeth. Consider diabetes in the background as a possibility. Consider depression again as a possibility. So you're looking for systemic diseases, local causes, and once you're left without any of these, your patient has got oral dysesthesia. They may well need CBT, certainly psychological help will be required, and some of them will then need additional treatment. You can use clonazepam as a suck and spit, or nortriptyline, or if that doesn't work, pregabalin can be helpful too. So in summary, we've seen some of the most likely painful conditions presenting to dermatology in this talk. The key is an early and correct diagnosis, so look for the clinical clues. Then look beyond what might be the obvious diagnosis. Is there an underlying trigger, such as a malignancy, that you need to find and treat? Definitely, I hope I persuaded you to use clinical outcome measures because they're simple, they're quick, they've been validated, such as the ODSS, and it's very versatile. Maximise topical treatments. It's the same treatments really for any painful mouth, and continue those alongside appropriate systemic treatment as necessary. Manage patients' expectations, because systemic treatments take 2 or 3 times longer to work in oral conditions than they do in skin. Thank you very much for listening.